Thanks, Mary. Thanks, team. Wanted to be sure to mention that we are, in fact, broadcasting live from Belmont, Michigan, our corporate headquarters. If you're in the area, we can send you the address. Stop on by. Loving the conversations. On to our next session. Hospitals are seeing an increase in the need for monitoring low to moderate risk suicide patients. Our next panel, Keeping the Suicidal Patient Safe Virtually, will share how they're caring for this growing patient population. I'd like to reintroduce our moderator, Dana Pico, AvaSure Director of Clinical Sales.
Hey, Dave, thank you. Hi, everyone. I'm back. So as I said, my role here is to conduct these clinical assessments, and I'm really excited to work with this panel because the #1 challenge I'm hearing across the country is how do we care for these patients that are low to moderate risk? We don't have the resources to go ahead and do that one-to-one sitter engagement. So it's so exciting to hear from all of you. I'm going to take a minute for you all to introduce yourself, tell us a little bit about your program, and what I think is really important to also highlight, where are you from in the country? Because we know different areas of the country have different laws and regulations about doing a virtual sitter for these low to moderate suicide risk patients. So I'll start with Debbie. You can go ahead and go first.
Hi, I'm Debbie Cronin. I am at St. Peter's Health in Helena, Montana. We are a 99-bed non-for-profit hospital, and we currently have 10 cameras in use.
Thanks, Debbie. How about you, Wesley?
Hello, my name is Wesley. I'm from San Antonio, Texas, with Methodist Healthcare, Methodist Hospital, Methodist Children's Hospital. We currently have 35 cameras in use.
Excellent. And then last, go ahead, Debbie. Oh, I'm sorry, Kim. I apologize.
My name's Kim Beckett. I'm the manager of Ascension, Michigan, Virtual Safety Monitoring Hub located in East China, Michigan. We currently monitor 14 out of the 16 Ascension, Michigan hospitals, and we have 224 cameras. And on Monday, we just celebrated our 4-year hub-iversary, and we have monitored over 4 million hours.
Yay!
And over 57,000 patients.
Everybody virtually give her applause. Yes, that's amazing. So my biggest question to all of you, and I'll start with you, Wesley, because you're down in my bottom right. So when you started the TeleSitter program, was your behavioral health or your suicide ideation patients in the forefront of your thinking of go ahead developing this program?
They actually were not. Our main focus was actually on our fall prevention, and that kind of came along a little bit later on, but it's actually been a cornerstone right now. So, that was our main focus with falls.
So when you started to look at this demographic of patients, what was one of your motivating factors? Was it resourcing? Was it a higher need of patients in the hospital? What was your motivation to go ahead and move forward with this patient population?
I would say it would be a combination of both. We had a lot of suicide risk patients in our facility. Having over 1,000 beds, we do have, a lot of patients that come in that score within that low to moderate range, and we were actually using one-to-one sitters. So we were having to pull a lot of our nursing support resources away from the bedside to be able to, monitor those patients. So that really became the focus of being able to put those support staff back on the floor.
Perfect. And then Debbie, I'm going to go to you because in Montana, you're kind of a big state with lots of space. How did you handle your program, and what made you go ahead and bring on the suicide ideation patients?
Well, we got AvaSure in the spring of 2020, and I don't know, many of you know, but Montana ranks one of the top 4 states in the nation for suicide. Yeah, Montana's high for suicide rate. So, but when we initially brought AvaSure into the organization, it wasn't to monitor SI patients. It was, as Wesley said, more so to try to get our CNAs and support staff back at the bedside. We were even having administrators sit with our one-to-ones. So yeah, we knew that we had to do something. So that was our main purpose of bringing AvaSure in, was for fall reduction, and then it evolved into suicide.
Okay. And Kim, same question to you. You are a big organization with lots of cameras in place. Talk to us about your journey bringing in those type of patients.
Well, initially it was for falls. We also did include suicide in our initial policy. The sitter cost is outrageous. And like they were saying, they were pulling directors, administrators. And then we found that we could use this virtual tool and be able to monitor multiple patients at once. So, you know, it was a great resource.
So as I'm walking through these hospitals and talking to these different leaders across the country, one of the biggest challenges or barriers I keep hearing is, well, you can't use virtual telesitting for our suicide ideation patients. I'll start with you, Kim. I'm going to go in reverse this time. So Kim, why don't you talk to me about how you were able to get over that barrier, especially because you're covering multiple locations, and what processes you put in place to make sure that you are using the virtual telesitter for those low to moderate risk patients.
Correct. And you really want to make sure, because most health systems have multiple policies with suicide. So you really want to make sure that they all align, and developing processes for your technicians. So what we do is if we're monitoring a lower moderate suicide risk patient, we have a checklist to look for. We want to make sure they have a safety tray when their food is being delivered, make sure that they don't have any extra furniture, be aware for tubing that they may use. We've had multiple good catches of suicide attempts, not only for our suicide patients, but also for patients we weren't even monitoring for suicide. Once you start getting those good catches, you really have to share them with the hospitals to get their buy-in, you know, with the program and getting leadership on board. And I was very fortunate in Michigan to have leadership that partnered with me, which really made our program a success.
Sure. And then what about you, Debbie? What kind of policies did you put in place and practices to bring these patients on virtual telesitting?
Yeah, well, originally, when we were, like I said, struggling to provide one-to-one care at the bedside for our SI patients, I partnered with the ED director, and she started, you know, pulling some numbers and such. And basically, we also had to revise our policy. We use the Columbia suicide screening tool. And so revising that and just meeting with providers, going to medical director meetings monthly to try to encourage doctors. And it was a slow process getting people on board, but the success spoke for itself. We, on an average, only monitor about 10 patients a month for SI. We don't have a large volume. We have an 18-bed emergency room.
So, in that
did I answer that question?
Yes, perfect. So, I want to kind of dovetail on that. So, you're starting the evaluation in the ED, correct?
Correct. That is where most of our patients enter the system, is in the ED. And each patient that's admitted to St. Peter's does receive the suicide screening. Perfect. And then once they are identified or answer, you know, yes to some certain questions, then it's in our policy that the provider or the mental health professional can initiate the telesitter for the moderate to low. We don't monitor a lot of low risk. We mostly monitor the moderate risk.
Okay, perfect. So Wesley, the same question to you, and the reason why I'm asking all of you, because you come from different areas of the country, and I think it's important to hear that you can do this all over the country. And for you, Wesley, why don't you talk about Texas and what you had to put in place to make sure that you are obviously within your guidelines, but you're also keeping these patients safe?
Right. So whenever we first started, it really took looping in our regulatory compliance managers, really understanding what we can and cannot do, you know, specific to our area. And then from there, we actually went to unit leadership and, you know, roundtabled with them why we were rolling this out. And then it really went unit by unit, just huddling with the staff, explaining the why behind it, you know, explaining other facilities that have, you know, utilized this process. And then we had to, you know, really look at our policy, making sure the facilities within our health system are all using the same policy regarding low to moderate risk suicide patients utilizing the virtual sitter. And then from there, just going back, keeping open lines of communication through the rollout process.
Perfect. So I did meet with an organization last week, and their biggest barrier, and you guys can tell me about your journey, they said their biggest barrier was to get physicians on board with this, that they have some physicians' philosophies were that if they are at any rate a SI patient, that they have to have that one-to-one sitter. And so they were feeling that that was going to be their biggest barrier, is from the physician component. So I will start with whomever had any kind of challenges or discussions, we should say, with your providers, and tell me about that.
Well, I could share some successes.
Perfect.
And that's how we got most of our providers on board, is that, and this came from Jennifer Williams, who is our clinical specialist there with AvaSure, is that she suggested that you do dual, that you still put the SI patient on the camera, but then you have a sitter, maybe just sitting potting right outside the room. And then, just time tells its story with those positive outcomes, not have the one-to-one sitter interact, but leave it mostly to the camera and to the monitoring staff. And that's how we got our providers more on board, was just slowly over time. And then now, here we are. We've been monitoring SI patients for just a little over a year, and it's very successful. Our providers don't even hesitate now to order, to get the camera.
Perfect.
In.
Great. Wesley or Kim, any provider feedback you want to let our audience in on?
I think a big thing, which I have done a few times, is presenting to the chief medical officers and the chief nursing officers, just so they have an understanding of the program and the good catches. We do have to circle back with some new residents that we're starting to see a little bit of a trend at some of the hospitals. So making sure we get on the agenda to meet with those new residents so they know what the camera is used for and, our good catch stories.
Perfect. And Wesley, anything from you from a physician standpoint?
For our facility at the beginning, we did have a lot of pushback from providers, mostly just we had to focus basically on the culture of it, just getting them to understand. Again, it all goes back to the why and communicating that. We do have a great senior leadership group here at our facility, and they were able to really help, cascade that out to the physician groups. And then similar to the other facilities, as new providers come on, we do have to readdress it. But again, it speaks for itself. We did also we were calling it the cohort. So we would have the virtual monitor in the room, and we would have that sitter outside the room for the initial phases of this. And then once we were able to show that our VMTs were able to interact with the patient in a timely manner, everyone was much more comfortable with it.
Perfect. So the other question I get asked oftentimes are, who's going to actually be on the other side of the camera? Can you talk to me about, are you using mental health associates? Are you using your traditional video monitoring techs? Tell me what that looks like, because I think people are a little fearful because it's something new to their environment of care, so they want to make sure that those patients are well taken care of. So I'll start with you, Kim, this time. So if you can tell me who those people are monitoring those patients.
It is our traditional video monitor techs. We do have the AvaSure suicide module, which is excellent. And when they are new, we make sure we go over the process as they get their first few suicide patients monitoring. We also do limit the number of suicide patients because we are a larger hub. We want to make sure that they don't have 10 suicide patients that they are monitoring. And we also have lead techs are on board that we know during every shift who our suicide patients are. So the leads can also do a double check, look into the room, see if there's anything that the patient may harm themselves with.
Perfect. How about you, Debbie?
Yeah, I agree totally. How much that e-learning module for monitoring patients at risk for suicide helped my group also. Just being a smaller hospital, only monitoring up to 10 patients at a time, I have three monitoring staff for nights and three on days, and they're a tight group, very consistent. They learn from each other, share from each other. So that's been a huge part of our success too, is not having, multiple people floating in and out of that camera room monitoring. This has really allowed us to focus on the education and that safety of monitoring patients.
Mm-hmm. And Wesley, how about for you?
For our facility, we do use our just our regular virtual monitor techs. Most of our techs, though, they're very seasoned. They've sat with suicide risk patients as one-to-ones. And for our facilities, we actually rotate our sitters through to our virtual platform, just so that they are, keep their skills up with monitoring suicide risk patients from a distance. And then we also always pair them with what we consider our core or our lead staff, just so that they're able to have a little bit more oversight as well.
Perfect. And so what about, talk to me about any kind of technology you have in place to kind of augment this. So for instance, are you using your EMR with order sets that help kind of drive this decision-making process? What are you doing to make it easier on the nursing side to make these decisions for these patients? So I'll start with you, Wesley, because I haven't started with you yet.
So for our facility, nothing integrates over into our platform specifically. We do have a tool that we use. It's called the NATE tool. That's actually pulling some data from our EMR. And then also a lot of it's nursing driven. So once the nurse identifies, we are using that Columbia suicide risk assessment. So once the nurses do their assessment and the patient scores low to moderate, there's that communication with the physician. And then a lot of the process is just driven by the nurse to communicate that, we want to monitor this patient.
Perfect. And Debbie, are you using any kind of technology from your order sets or any kind of integrations to anything to help make these decisions?
No, we're same as Wesley. It's mostly nurse driven.
Perfect.
Provider driven
Sure.
for the SI patients.
Right.
Yeah.
And then what about you, Kim?
Same in Michigan. What I will say, since we have so many new nurses, when we do admit our suicide patients, we always educate them about the moderate suicide policy. And a lot of times the new nurses don't realize that they can't be left in the bathroom alone. And they think it's our role, and that's the suicide policy. So it's an opportunity for us to also educate these new nurses that don't know about the suicide policy. So.
Right. So you bring up a really good point, education, right? We know that's key to success for these programs to work. So talk to me about, especially when you made the decision to move from not just for falls risk or for elopement and other components that you use at telesitting. Talk to me about what type of education was involved, especially when you're looking at this SI demographic. So Kim, I'll start with you since I left off with you.
So education for our techs specifically?
For your techs and your nurses, both.
Yeah. So like I said, during admissions, we always give the nurses the education, which is very surprising on how many do not know that. Same goes with the fall risk. For our technicians, I share stories of what have happened at other ministries, unfortunate stories where people have been successful with suicides. And sharing those stories really hits home, and continuing sharing when we do hear those negative outcomes. Doing quality checks. We do quality checks. Like I said, the lead techs will do that, making sure we have our processes, and we have to stick to those processes. We have to have escalations in place just in case if we do hit the stat alarm. If someone is doing a suicide attempt, no one's coming to the stat alarm, we will initiate a rapid response. So we have to have those in place. Fortunately, we have not had to do a rapid response for a suicide attempt, but to think of anything that could happen.
Perfect. Wesley or Debbie, any kind of formal education or additional education you had to provide for your monitor techs or your nurses?
For the nursing staff, well, actually the nursing staff and our techs, they all were assigned HealthStream modules, and it went into, again, just the brief overview of the system, as well as the connection between our policies and procedures and the actual virtual sitter platform. And then for our techs, also the same thing, just sharing the stories. We do have a weekly, we call them accountability, and also like roundtable discussions with our core staff to just discuss, any challenges that they're having with monitoring our suicide risk patients.
And Debbie, anything from you?
Yeah, really nothing to add more than the e-learning module that all of the monitoring staff had to watch. We also use that quick guide as a template from AvaSure, and then we just made modifications specific to us, posted it at all of our nurses stations, on all the wings, went to staff meetings to educate the nurses, and then all the other things that the others mentioned.
Right. And it's obvious from this discussion that these patients are not just isolated into a behavioral health unit, that this technology can be used starting in the emergency department all the way through. You all will agree with that? Like, it's not just for a behavioral care area.
And I also wanted to mention some of our smaller hospitals, they will have a physical sitter for our high-risk suicide, and they will have their televisit to see if the patient will be downgraded to a moderate. So at least we're in there, we're knowing the behavior of the patient. And we've also been in inpatient units with a high-risk suicide with a one-on-one sitter, just as a, just double. And we had multiple times where the sitters have fallen asleep, and we're, waking them up and notifying the staff. So in my mind, if you have the cameras, even with the high-risk suicide, because you don't know what that sitter's doing in the room.
So it's just another layer of protection for the patient and that sitter, right? So what about when you started to initiate this workflow? What did the family members think of it, that you were going to not have that one-on-one sitter with those types of patient populations? Was there any pushback from families or care providers from the family side of the equation?
I have not in Michigan, but what I tell my techs, it's really important to introduce, because you have this camera in the room, it can be a little scary. So just introduce themselves and let them know they're here to keep the patient safe. And we have not had any pushback at all.
We haven't had any in Montana either from our families.
No, neither here. We kind of expected it first, and we were actually very surprised that we did not have the pushback. Any confusion from the family side, we found that it was going back to the tech introducing themselves. A couple of times the techs had forgotten to do that part.
Right.
So.
And oftentimes people think that you need a consent, which we explained to them, since we're not recording, we don't need a consent for those patients. My other question to you is, are you using it for just the adult population? Are you using it for your pediatric population? Talk to me a little bit about your population demographics, because again, in organizations we know mental health is obviously very prevalent in our communities, and we want to make sure that all of our patient demographics are covered. So Wesley, can you start with you talking about your demographics of your patients? Is it adults? Is it peds? Is it a combination of those both?
So we do have a combo of both. The majority of our low to moderate risk SI patients are on the adult side. We do have a children's hospital here. For the most part, those patients do score high risk, but we do have a few that will be in that low to moderate. And for the most part, we've had great success of implementing that over in the children's hospital, and again, just communicating with the family. A lot of the times, the patient's family members are still at bedside, a lot more than on the adult side. So just being transparent with them that the devices don't record and the why and all of that. But overall, it's been successful, and I think we've actually seen an increase in the amount of pediatric patients that we've been using the cameras for recently.
Okay. And what about you, Kim?
Yeah, adult and pediatrics. Unfortunately, increase in pediatrics recently, but the younger patients really think the cameras are neat. And we had one girl just so amazed whenever we would move the camera. So she was like, she just thought it was so cool. So it really distracted her. So
that's good.
Yeah.
And Debbie, how about your patient demographics out there in Montana?
Same, both adults and peds. And in fact, our pediatricians were the providers that were more hesitant to have their patients monitored with this. It was easier for us to sell it to the ER and to the hospitalists. But now, again, and it's unfortunate, same, our pediatric population, we're seeing more.
Right, I know. So if you had to go back in time and give yourself a piece of advice about rolling out virtual telesitting for your SI, low to moderate risk SI patients, what would that be, that piece of advice moving forward? If you could have gone back in time and and start it over. And what was that lesson learned or that piece of advice you'd give yourself?
Well, I know for myself, our inpatient geriatric psych unit is our only department in the hospital that we can't use the cameras in because of the ligature risk. We only have the cameras on the poles. So of course the cords and other reasons, it's the ligature risk. So I would relook at putting a different type of product in the room rather than the camera. I know the Guardian, the device the gentleman introduced, yes. I know it's a Guardian, but that wasn't available when we purchased the system. But,
right.
Yeah, just doing that. I think that our inpatient behavioral health unit would really benefit from this type of safety device.
And that's why we do these assessments too, to talk about that and talk about what device would make the most sense for your environment. So what about you, Wesley? What advice would you give yourself if you were going back and starting this process again?
I think going back, I think we did really well with the individual unit huddles, but I think looking back, maybe including it more in like town hall discussions, stuff like that, just where everyone, is together and able to collaborate on the entire discussion, I guess you could say, together, versus having, individual departments bringing up one concern versus the other, not really having a ton of communication amongst the departments. So that would probably be my biggest learning.
Right. And then Kim?
Getting more cameras. I think a camera should be in every room, and I'm going to keep pushing for that.
Yay!
So, I mean, I truly do, especially right now in the Guardian Access, I think is going to be great. So I hope that we can get some of those in our facilities.
Yeah. And then, so, I was probably going to ask it because you all mentioned it. So if you can share, obviously we're not going to do PHI, we're not going to talk about specific patients, but we would love for you to share a good catch to kind of help motivate the folks that are watching that are maybe a little bit nervous to start this process for this type of patient. So I'll start with you, Wesley. Tell me a good catch that will make everybody feel really good this afternoon.
Well, we've had quite a few. And this actually involved a low-risk patient. So this patient was actually able to Uber, if you will, some materials from outside into the facility that the patient would have been able to, caused harm to themselves with. And had our camera not been in the room and our techs engaged in monitoring that patient, it probably would have had a very different outcome. So that was a really good catch recently.
Yes, and you share that with obviously the organization and in your huddles, correct? Yeah. And then what about you, Debbie? Give us a feel-good moment.
It may not feel good, but it's one of them that just happened most recently that's on my mind. Our TeleSitter observed one of our security guards entering a pediatric SI patient's room and was inappropriately overly aggressive with the 8-year-old, and she immediately put the stat alarm on and notified the house supervisor, and the chain of events occurred after that. But if the TeleSitter wouldn't have been, if the camera wouldn't have been in the room, it would have been, his word against other, the word. So it was a benefit that the camera was in the room.
Yeah. Yeah, and that's a scenario that we don't even really think about when we're looking at this solution, right? We're thinking more about the patient and not about the impact to the patient and the people interacting with that patient.
Yep.
Yeah. And then Kim, I'm going to let you tell us a good catch, and then I've got a lot of questions for you guys, so be ready.
We had a patient who the tech heard start saying some bizarre stuff and was taking the heart monitor, was hitting himself with it. So called the RN and said he's saying some really bizarre stuff. So the RN was heading in there during that time, took the leads and started strangling himself. Stat alarm was in there. Nurse was coming in, then took the sheet while the nurse was in there and was trying to choke himself. So that was our one good catch. I just wanted to add one other one because people don't think of it, but the garbage cans and the liners. We had a patient and our techs knew to look for that because that is used very frequently. Put it in their mouth, they hit the stat and then continue to choke herself with it. Staff got into the room. So no harm to the patient. So
Oh.
those are some of our good catches.
Yeah, that would be a good one for us to add to our toolkit when they're looking at the rooms to make sure that there's no garbage liner. So that's a good one.
And with the cameras, we can zoom so closely, closer than having a physical sitter in the room. So that's a huge benefit.
Yep. So you guys ready for some Q&A from our vast audience out there in the world? The first one is, have you ever had a Joint Commission visit while you guys were using AvaSure for that SI patient? And what was Joint Commission's feedback on it?
So for Michigan, we actually just did a run through just a couple weeks ago. Also, the big thing, of course, it has to be low or moderate suicide risk. You have to make sure you educate your staff that this is not recorded. We had at one of our sites that thought it was recorded. Oh, no consent. Oh, no, we're like, no, it's a live feed.
Right.
HIPAA compliant. The nurses in our policy, they have to do hourly rounding. It needs to be documented, along with that the patient is being visually monitored.
Perfect. Debbie, Wesley, any feedback from Joint Commission being on site while you're using it for this?
So we did have a recent Joint Commission survey, and same thing. One of the biggest questions they asked was, do your devices record the patient? What kind of consents do you have in place? And after, we educated them on the fact that it does not record, that basically eased up most of those questions. And again, just reiterating that it was just for our low to moderate risk patients.
Right. Same with you, Debbie?
We're not Joint Commission, we are DNV.
Okay.
And we did have a virtual survey in January of this year, and nothing came up. But I believe they're going to be on site, so more to share on that in the future.
And now you can learn from these folks to make sure that people know that it's not recording, and educate the staff to make sure that they can answer those questions. How about this? Do your techs have different ratios if they're watching a suicide patient versus the other demographics of patients? Is there different ratios for that?
Not in Montana. The monitoring person does have the ability to move the patient to a certain position on the screen. So they'll tend to put the SI patients grouped together at the top. But no, we do not have a limit with them only monitoring 10 patients, up to 10 patients.
Okay. Wesley or Kim?
Our facility does not. One thing they will do, if their ratios are a little bit lower, they will actually, because we have 2 techs usually at a time, they'll add the patient to both screens just for an extra set of eyes.
Will you repeat that one more time? They'll add what?
So they'll add the patient to both of their screens.
Oh, okay.
So we have 2 techs that sit next to each other. So if they have a patient that's maybe a little bit more active, that's a suicide risk, they'll add them to both screens.
Oh, so you'll have 2 virtual monitor techs watching that patient from that perspective, so that you can get extra set of eyes on it. That's a really smart idea. And Kim, what about you? Do you have different ratios for your suicide ideation patients?
We don't, because I will tell you our elopement patients are probably the most busiest, but we do try to keep it to 2, moderate and elopements. Just depends on how many that we have. But with all of our patients, we could have a fall risk patient that's super busy. We always tell our techs, let us know if you have, we call busy patients, and our lead tech will reassign them to even out the load. And the lead techs will also check that also, just to see if they're busy screens.
So I'll guess this one at the end. This was a kind of a funny question, so we're going to wait till the end for that one. So what about with your SI patients and where did that question go? And being able to, what about documentation and making sure that all of your I's are crossed and your T's are dotted? Are you guys doing any kind of, with those patients, any of those 15-minute check-ins with them from a virtual perspective that a lot of the behavioral health patients need? Are you using any of those type of tools or components for those patient demographics?
No, we do not in Michigan, which we did get a little pushback in the beginning, but that's eyes off of the screen. It did not provide any value. It was if the patient was awake, alert, oriented. Once we pointed that out to them, they're just used to that and said it just is a distraction.
Right. Wesley or Debbie? Go ahead, Debbie.
We do, our monitoring staff do still on paper the Q15 checks. We haven't had any misses with eyes off the screen, but good point.
So you're doing it from a paper perspective. You're not using any other tools like applications to do those 15-minute check-ins. You're doing it all.
They do a room, the offgoing at handoff. There is a room sweep that they do on paper also. Between nurses, but the monitoring staff are just documenting Q15 on paper.
Okay. Wesley?
In the beginning, they were doing the 15-minute documentation, and then we switched them over, and they just do their normal hour documentation on the patients.
Okay. And then what about handoff when you're doing, and you can talk from both your SI perspective, but then also your falls risk patients. What are you doing today when you're handing off from your virtual monitor tech to virtual monitor tech to make sure that all information is being, transferred, knowledge is being transferred to the next VMT? I'll start with you, Debbie.
Yeah, they have the admission form in their little room, and so they do have that expectation to follow that, and then they even share how many times the patient has needed the stat alarm, how many verbal interventions, those types of things. So they go through that at each handoff.
Okay. Wesley?
Our techs will start with, they'll go room by room, they'll click on the room and actually go through the notes section on the patient. And then after they go through each of those, they'll, similar to the other facility, they'll go through and describe how many times they've had to verbally interact with the patient or use that stat alarm.
And then Kim?
Our shift changes pretty fast because everything is in the patient profile. We do a double check to make sure the patients are accounted for to the paper, and just making sure, again, that they know the processes, because, a lot of times they might be busy on night shift and day shift, that they're fine. So we don't review how many stats or verbals, but if there's anything key, an attempt or anything like that, that would be communicated and also put in the side notes.
Perfect. So if you could go back to when your program started, and again, we're trying to think of those folks that are just getting started on this journey, would you recommend that they go ahead and incorporate the SI patients from the very beginning, or do you think it's better to stand up the solution for your falls risks and other demographics and then bring in your SI patients? What do you think would be the best course of action for them from a deployment perspective? And I'll start with you, Kim.
I personally think doing it in the beginning, just so they're not confused. You might miss some people. I think that's what we did in Michigan. And like I said, not really much pushback with it.
Right. Wesley?
I would agree. Doing it earlier is better, just because you're going to have a lot of the same questions whenever you come around to, implementing it for your suicide risk patients. So being able to address it at the beginning, I think would be more beneficial.
Right. And Debbie?
Yeah, and I would agree. Would agree wholeheartedly. And I was going to add something else, but I forgot.
It's all right. We can come back to you. We have 8 minutes left. We have a lot of time to hang out and chat. It's fine.
Oh, I know what it was.
Yay.
I know what it was. Yeah, and this may have already been previously said, but there are some demented high fall risk patients that are just as much time consuming as an SI patient. So there really is no hard evidence of needing to do the fall risk patients are trying to maintain devices first rather than doing it all, together.
Right. And you raise a very good point, right? Because when we're thinking of behavioral health, it's not just the SI patients, right? We have patient demographics that would benefit because we're using that one-to-one sitter. One that comes up a lot is maybe our youth folks that are having eating disorders and being able to use this technology for those types of patient demographics. So from a use case scenario, obviously the falls are obviously front and center, right? That's what we know everybody's thinking about. But what types of patient demographics do you, after being deployed for a while, are you seeing most often? And what patient demographics do you think could benefit from using a virtual sitter? And I'll start with you, Kim.
Well, I think, like I said, it's nurse driven. We go by, whatever the nurse is. Pediatrics has been, I didn't think initially, I thought it would be more of adult population, but like I said, they really find the cameras amazing. And we also started a new pilot here at our Detroit hospital where we're able to take control of the TV in the patient's room and initiate sing-alongs for our younger patient population, relaxation videos, patient education videos also. So we do that for our falls patients. So that helps with the relationship. We have two-way cameras at our Rochester location, but our other sites we don't. So just being able to connect with them that way has been a huge success.
Right. And then what about you, Debbie? You kind of talked about the dementia patients, that's a demographic, and obviously that falls under that behavioral health umbrella. What other types of patients have you been using it for, but then also you see a benefit for?
Right. In Helena, Montana, it's mostly from the fall risk patient, our geriatric population. We don't have, multiple department, multiple service lines here. We just have a medical floor and then a surgical oncology floor that the camera's most utilized in.
Right.
So it's for the falls and then our pediatric population also.
Okay. And Wesley?
I think, primarily we do use it for the falls, but as well as it being nurse driven, we always tell the nurses, especially whenever they're first joining the organization, when they're in doubt and they're not sure if their patient would benefit from a camera, just request a camera. There's no harm to it. And also recently, now that we have really good buy-in from our pediatric physicians, a few of them actually brought up a good point of using the camera to monitor for, I think someone mentioned it earlier, eating disorders. We have, a high population of that here that I actually wasn't aware of. So we've been able to, start utilizing those cameras for those patients.
Right. And Kim, you mentioned, and a lot of people maybe on this symposium aren't aware of the two-way video camera capabilities we have. I know Dave showed you the Access device where we can integrate with your television and have that two-way. Can you tell the audience a little bit about the benefits of using that two-way technology as opposed to just the one-way technology?
Yep. So it gives that patient that room a face to look at, which is huge. And also the clinical staff, because unfortunately, sometimes the clinical staff can be a little harsh to our sitters. So them seeing that there's a person behind there is huge.
Yeah.
I also wanted to add, over the last week, we've been watching infants for infant abduction, which is new for us within the last week.
That's
and
a good one.
I never thought we would be monitoring for that, but we are.
Right. Yeah. My background is neonatal nursing, and I was just talking to some folks in a NICU outside of the state of Michigan, but they were saying that they're using it for watching family members too, for like Munchausen, but then also, unfortunately, we have a high addiction rate population, and sometimes they're actually taking medications from those babies and using it. So it's a nice use case for that as well. It's just to kind of make sure our patients are safe, but also making sure what's going on in the room is safe for those patients. So our other question is, Kim, it has been brought to our attention that you have an amazing award behind you. You want to share what that award is and tell us a little bit about it?
Yes.
So
this is the 2019 AvaSure Safety Net Award. And I'll be honest, it was somewhere else, but I put it in my view for this. So hopefully we win again very soon. That's our goal. But yeah, we got our pictures taken with it. We're going to take it some places. So took a while to get here because it got shipped to Texas. So I just received it here probably about 10 months ago. So
yeah. So we expect it in your bag everywhere you go when you travel with your family. Take it out like Where's Waldo type of thing and just set it everywhere and just share it to our website. That would be great.
yeah.
So we only have a couple minutes left. So what parting words and wisdom would you like to share with those folks, especially those ones that are really timid about going forward using our technology for those SI patients? What piece of advice would you give them? And I'll start with you, Debbie.
Go for it. I mean, just no regret. It's possible. It's efficient. It's effective. And we haven't had, I mean, it sounds like you've got 3 organizations here and not any of us have had a negative outcome from monitoring an SI patient. And there have been attempts, right, probably in all 3 of our organizations, that the camera has caught and prevented any harm. So
very nice. What about you, Wesley?
I kind of have to agree. Don't hesitate. You know, of course, there's going to be pushback from the frontline staff, from providers. Just education is key. I think the results speak for itself. And whenever you look at, again, the 3 organizations that we have here today, you know, it's proven to work.
Right. And last but not least, Kim,
You know,
take
we
us
have-
on
you know,
home.
in these times, we have to come up with new solutions. One thing I wanted to share when I went to one of the sites is one of the new nurses being trained, a huge dissatisfier for her was that her nurse that was precepting her was pulled to sit with a moderate suicide risk patient. And that was the feedback the preceptors were getting. So just do it and they won't be sorry.
Right. Well, we can't thank you enough for spending the afternoon with us. I know this was a valuable session for many organizations. Like I said, as I traveled the country, this is a huge pain point across the country. We know that we're finally embracing the mental health crisis in this country, and people are feeling a little bit more comfortable coming forward. So we need to have tools in place to make sure that those patients are safe, and we give them what they need to keep them safe, but then also think about our workforce. So we appreciate your time. Have a great day, and thank you for joining us this afternoon.
Thank you.
Thank you.
Bye, everyone.